Uh, it's always nice to have some surprises. Okay, so the second speaker will be second speaker. I'm going to start with the first speaker, my colleague and friend, Dr. Hani Sabbour. He's a cardiologist, electrophysiologist from Cleveland, Abu Dhabi. And Dr. Hani, mashallah, you are there. So he's going to talk to us about emerging obesity medication. Dr. Hani, looking forward to your topic.
Thank you very much, Dr. Abdullah and Dr. Khadija. It's always a pleasure to be with both of you in these really important talks. I got the wrong one. So I've been tasked to talk about obesity and its impact and how we treat. So I decided to take two portions of obesity and focus on them today. And I've sort of modified slightly the title, if the chairs will permit me. Obesity is a cardiometabolic disease. We're going to focus on hypertension and HFpEF, recognition, diagnosis, and modern therapeutic advances. So this is the agenda for today. So the WHO data is telling us from 2016, there are about 500 million adults with obesity. And this is highly prevalent, and we actually are looking at this data systematically in the UAE. Hopefully we'll have a publication very soon in children. We are getting an epidemic of childhood obesity. And of course, these patients will always become adults with obesity with all of the attendant metabolic complications. So it's a tremendous problem if we don't start treating it from the first onset. Obesity in the Gulf countries is quite prevalent. If you take a BMI cutoff point of 25, 68% of people in the UAE, 63% of people in Oman, more in Qatar and Kuwait and Bahrain. So really we're dealing with a pandemic of proportions that are going to be very difficult to manage unless we recognize, diagnose, and treat. Now, weight status is classified according to BMI and waist circumference, as you know. The main thing is this: when we look at people from South Asia and the region, the classification differs somewhat because you can actually have metabolic complications in men and women, even if the waist circumference is significantly less than that in European or international classifications. So it's important to recognize that the waist circumference may be a fooler in our patients in the region. Because you see here the difference is an almost 20% difference. Patients are getting cardiometabolic complications with a waist circumference of 78 in men and 72 in females, as opposed to where the cutoff points in European populations, which are much higher. The BMI is essentially the same though. So I think we have to take that into perspective when we're looking at the patients. So here's just an introduction about what's cardiometabolic risk. So it's the overall risk of developing type 2 diabetes and or cardiovascular disease, such as MI and stroke, due to modifiable risk factors. And we talk about modifiable risk factors, which we all know, like age, smoking, high LDL, hypertension, diabetes, and family history. But the additional modifiable risk factor, which we're trying to address today, are factors closely related to abdominal obesity, especially intra-abdominal adiposity, which are insulin resistance, low HDL, high triglycerides, which is called the atherogenic dyslipidemia, and inflammatory markers. And it is a continuum of risk that starts essentially in childhood with the abdominal obesity and then extends to the traditional risk factors as well. Now, we're all familiar with this clustering of components. Now we talk about blood pressure in the sense of 130/80. We talk about the high triglyceride, low HDL, the atherogenic dyslipidemia. We also have defined the BMI more than 30, which increases the risk not only of the above, but also of sleep apnea. And of course, the waist-hip circumference, which, as I've mentioned, has a specific connotation in our population. It's actually going to be lower. Now, the insulin resistance and impaired glucose handling is part of the definition. And the WHO definition also requires microalbuminuria. And here, the albumin-creatinine ratio of 30 milligrams per gram is very suggestive of dysfunction of the endothelium and a target organ damage. And all of this actually happens before the patient meets the actual diagnosis of diabetes, as you see here. This is all an insulin resistance component. Now, when you look at this in a global perspective, this encompasses patients with metabolic syndrome and obesity, type 2 diabetics, non-FH hypercholesterolemia, patients who have had a cardiovascular event, FH patients, and chronic kidney disease. These sit right in the middle with high-risk dyslipidemia. And this is oftentimes how these patients come to your clinic looking for advice on an abnormal lipid profile. Now, I will also remind you that the American guidelines have been very specific about metabolic syndrome as a very powerful risk enhancer. And right here in the center of the slide, we see increased waist circumference, and parallel to that, of course, as we mentioned, BMI attached to the metabolic portions of dyslipidemia. Obesity itself is a complex multifactorial disease with changes in energy intake and expenditure. The brain is a very important organ in this disease, including its effect on adipose tissue, the pancreas, gut, genetics, and medications. In addition, there's the unavoidable impact of environment and psychosocial factors, as well as the patients and normal people have a drive for food. So there are multiple portions of obesity. Part of them is executive and higher functions and motivation. Part of it is homeostatic functions, and heritability is 70%. And we are sort of fully aware of the fact that this is an inherited trait. There are many other impacts of this. This is like a meteor striking the earth because we have a huge amount of pressure from the outside, including processed foods that are high sugar and fat, large portions, all the time, home delivery, and accessibility of cheap, unhealthy food, coupled with the appetite system. Now, obesity is directly associated with multiple comorbidities and complications, primarily directly sleep apnea, cardiovascular disease, contributes to 23% of the ischemic heart disease burden related to obesity, which is also dyslipidemia, coronary heart disease, and CHF, diabetes and prediabetes. Obesity is supposed to contribute about 44% of the diabetes burden. In addition, non-alcoholic fatty liver disease, gallstones, polycystic ovary, up to 40% of certain cancers are associated with obesity, plus reduced physical functioning and arthritis. So I'm going to focus a little bit on hypertension as an obesity-related complication. So what is a normal blood pressure? According to the ESC, it's 120 to 129 over 80 to 84. The Americans are more strict, 120 over 80. And of course, if you have other factors such as diabetes and CKD, the numbers will change. Hypertension often causes no symptoms, but can manifest primarily with organ damage. And there are some weird symptoms that you see, like blurred vision, plus angina, chest pain, and shortness of breath in the advanced state. Now, hypertension is caused by many different things, but I'm pretty sure that we realize that weight, smoking cessation, and alcohol, as well as the genetic predisposition, are very important in causality. The diagnostic criteria, as I mentioned, are different, but the end point is whatever society you follow is to prevent the complications of hypertension with aggressive blood pressure control. Now, as your BMI increases above 25, there are up to 29, there are 3 times more likely to develop hypertension than non-obese patients. This is the reference at 21, it's 1.0. The relative risk when you're 27 or above is almost 3 times higher, and it's a continuous variable. And as your BMI increases, the likelihood of hypertension becomes almost certain. So a class 3 obese patient, almost 80% of these patients have hypertension, but even overweight and class 1 are about 60 to 80% likely to have hypertension as well. Now, regardless of the ethnicity, more hypertension, higher weight is a direct correlate. There's no question about this, and it's not a regional or race-related factor. Now, the presence of hypertension is very significant because patients with hypertension at 50 have a significantly lower life expectancy, about 5 years in both sexes, really, if you have hypertension. Obesity-induced hypertension is significant because it's accounting for a large component of what we call primary hypertension and about 5% of secondary hypertension, mostly driven by sleep apnea. How is it occurring and what is the factor behind it? Obesity directly triggers the sympathetic nervous system, increases the RAS activation, direct stress on the kidneys, and increases aldosterone, salt and water retention, and hypertension, in addition to triggering sleep apnea, which is the easiest reversible cause of hypertension. Now, in terms of direct impact on death, CV mortality is significantly increased in the presence of hypertension in a patient with a BMI over 25, as we see from this very well done study. So if you have only hypertension or hypertension with diabetes or multiple risk factors, mortality increases almost 2 to 4-fold. So it's a serious problem if you have hypertension and obesity. Now, I won't go through the algorithm for treatment of hypertension because you're all very familiar with this, but non-pharmacological therapy includes weight loss in obese and overweight patients, plus pharmacological therapies, and if the patient has a significant cardiovascular risk, early treatment is really immediately required. So we treat patients with primary agents such as ACEs and ARBs, CCBs, secondary agents such as alpha blockers, DRAs, and loop diuretics can be used in the later stage. In the patients with, and this is directly from the ACC guideline, in patients with BMI greater than 30, suggested treatments for obesity on top of antihypertensive therapies are recommended simultaneously. And if the patient's BMI is over 45 or 35 with comorbidities, ACC recommends also bariatric surgery because of the impact of hypertension and obesity on cardiovascular death. Now, there are many challenges in the pharmacological management of obesity-induced hypertension because the presence of non-alcoholic fatty liver disease will affect the utilization of certain medications, variations of plasma concentration due to the large body weight and soft tissue distribution, and of course, resistant hypertension requires the treatment of sleep apnea as well as multimodality therapies and the impact on the kidneys. Now, the reverse is also very true. Meta-analyses show that systolic and diastolic blood pressure drop by 1 millimeter of mercury per kilogram of weight loss. With dietary intervention, 4 kilogram weight loss is approximately 4 millimeters of mercury blood pressure, systolic and diastolic. Bariatric surgery, 52% reduction in body weight results in about a 15/10 millimeter of mercury reduction in blood pressure and hence cardiovascular risk. Many RCTs show that lifestyle modification can, in the short term, reduce blood pressure, again, 1 kilogram going by 1 millimeter of mercury. Unfortunately, though, as you all know, this is never really sustained. Now, looking at different studies with different agents that are approved for weight loss, remember, these are not blood pressure lowering medications, but were mentioned in the ACC guideline, phentermine topiramate and liraglutide are the two that had a significant or robust weight loss, and with liraglutide 3.0, specifically a significant reduction in the systolic and diastolic blood pressures together. Now, the SCALE study is a long-term study with high-dose liraglutide, and with the 3.0 milligram of liraglutide daily, there was and in terms of contribution to weight loss, a significant reduction in A1C and fasting plasma glucose, but also systolic blood pressure was significantly impacted in proportion to the weight loss seen in the long-term SCALE studies. How much weight loss is needed, however, to improve obesity-related complications? So with hypertension, you need to lose between 5 to 15% of your weight to continue to lose blood pressure. And as your blood pressure, as your weight continues to decrease, blood pressure comes down in a linear fashion. So clearly, the use of weight loss programs coupled with pharmacotherapy can have a really good impact on blood pressure. And finally, direct medical expenditures from hypertension. If you look at medication, it represents basically 18% of the expenditure, but hospital medicine is 56%. And clearly, if we're going to try and prevent complications of hypertension related to obesity, early use of medication and physician programs will significantly impact and reduce the cost from the hospital service. So to summarize this section, hypertension is often asymptomatic until target organ damage is seen, which is something we need to avoid. The prevalence is directly increasing with BMI, and hypertension with increased BMI is seen in all weight categories and all ethnicities. A kilogram of weight loss equates to a short-term blood pressure decrease of hypertension, and the hypertension-related expenditures can be significantly reduced from the hospital setting by early programmatic and thematic changes in treatment of hypertension. I'll move briefly now to obesity-related heart failure with preserved ejection fraction, because this is the common phenotype that is seen in the outpatient setting, particularly in diabetic and hypertension clinics. So the cost of 1 year in patients with HFpEF is significant, but a single admission will increase that cost by a tremendous amount, and it continues over many visits, and of course, if the patient has recurrent heart failure. And this is applied in Caucasians, Africans, African Americans, Hispanics, and Asians. So the total cost for heart failure is primarily driven by hospital-based treatment. So it's very important for us to try and prevent it from the beginning. So what is heart failure with preserved ejection fraction? It's a prothrombotic state which is increased in the setting of a normal ejection fraction. And this is the one that we see most frequently in the non-acute setting. This is the hypertrophic heart, diastolic heart failure, no LV dilatation, but it's a stiff ventricle in a patient who is obese, hypertensive, sleep apnea with metabolic syndrome. And this requires a near normal ejection fraction. It is characterized by a common symptom, tiredness, fatigue, and breathlessness, and lower limb edema, which in the outpatient clinic is often attributed to just being overweight or just being on a CCB like amlodipine. So it's often missed if you're not specifically looking for it. The risk factors for HFpEF are predictably diabetes, obesity, metabolic syndrome, and this has now been called the metabolic obesity HFpEF phenotype. If you measure these items in the blood, such as IL-6, TNF, and C-reactive protein, they're invariably elevated along with the atherogenic dyslipidemia and impaired glucose tolerance. The guidelines are relatively complicated, but you have some to have these mild symptoms. The echo shows an EF of 50%, but very importantly, the key diagnostic test is NT-proBNP or BNP above these numbers shown here, 125. And the ECG may show atrial fibrillation, LVH, and non-specific repolarization abnormalities. For those clinicians in the audience, if you have symptoms such as we mentioned, fatigue, lower limb edema, shortness of breath, and you do a BNP and an ECG, those should give you the immediate clue that there's heart failure in between. And if you do the echo, the EF is more than 50%, but don't be deceived because this is a HFpEF patient. It's very common. If out of 6.5 million Americans with heart failure, 1 in 33 Americans will have heart failure by 2030. HFpEF, which is seen in the outpatient clinic and often misdiagnosed, is 50% of cases and will be the most common type of heart failure. The prevalence of HFpEF actually increases in age, whether the females or males. Reduced ejection fraction is starting to flatten. So this is now the second epidemic that's associated with obesity. Many clinical studies have seen the incidence of HFpEF, and obesity is directly related to the prevalence and incidence of HFpEF. And it's a very important thing to recognize. If you see this metabolic phenotype, the obese patient, they very likely can have heart failure with preserved ejection fraction. And the proportion in these 3 large studies is anywhere between 36 and 53% in an outpatient setting. The prevalence, as I mentioned, is rapidly increasing, and I think it's going to be very important for all of us to recognize this syndrome. Now, HFpEF also increases over time with age and increases with body weight. Lean patients may have a slight increase of incidence as they get older, but overweight and overtly obese patients have a HFpEF somewhere in the order of 15% by the time they've had obesity for at least 5 to 10 years. How does it happen? First of all, there's aging. Secondly, there's hypertensive remodeling, vascular and ventricular stiffness, metabolic stress and inflammation, loss of peripheral vasodilatory reserve, and as people get more tired, they become more sedentary and they lose fitness. The chest wall compliance decreases, leptin levels increase, obesity increases renin-angiotensin, and BNP levels increase as well. This leads to increased circulating volume and sodium, inflammation, cardiac stiffness, renal worsening, and obviously, in addition to traditional risk factors like coronary artery disease, LV stiffness and filling increase. There are no approved treatments for HFpEF, although we've recently seen the Emperor Preserved study using empagliflozin show us a significant reduction of heart failure hospitalization. Diuretics and blood pressure control are the mainstay of treatment. Lifestyle management, believe it or not, seems to be the most effective measure to prevent this, and obesity management is very important. According to the treatment, you have to treat the comorbidities, which here, as we see, diabetes and sleep apnea and obesity are seen basically in the two central factors for the treatment of the disease. Diabetes, sleep apnea, and obesity, diabetes, sleep apnea, and obesity as well. In addition, we have to treat the symptoms. So, blood pressure control is key. Diuretics cause relief of symptoms. We have to manage the atrial fibrillation in patients with HFpEF. We use RAS blockers to decrease the likelihood of HFpEF. And of course, management of sleep apnea is very important in patients with AFib and heart failure. Some patients will benefit from mineralocorticoid antagonists and coronary vascularization if the patient has coronary artery disease. Now, sustained weight loss, caloric restriction in this study actually resulted in 7% weight loss, improved exercise tolerance by the peak VO2 went up by almost 14%, and improved MRI and echocardiographic measures of diastolic function. So this is probably the way for us to go forward and prevent and treat this disease as well. Metabolic surgery has been very powerful and has shown in this long-term study, 8 years from surgery, to show a almost 15% reduction of cumulative incidence of heart failure over time compared to this control group where it was significantly higher and increased with time. So in summary, HFpEF is a disorder when the heart fails to keep up with circulatory demand with filling pressures. Obesity induces hemodynamic and biohumoral changes, leading to structural and functional changes that result in HFpEF. Treatment approaches include heart failure symptoms, risk factors, and diuretics, and significant weight loss results in increased exercise tolerance, improved MRI and echocardiographic measures of diastolic heart function. And with that, I will stop and turn it back to the chairs for any questions.
Outstanding, Hani. Thank you very much for this overview. I think it brought us to the practice what we do. I mean, heart failure is what HFpEF is very common. Hypertension is a major risk factor, as you know. So obesity was epidemic one stage, and I don't know, become maybe pandemic nowadays. It's 1 in 3 in Emiratis. And if you look at, is it a risk factor, is it a disease? We don't know. I mean, at least it leads to lots of problems. Any questions to Dr. Hani, because he has to leave after this? Any question from the attendees? I want you to be active. Come on, yalla, bismillah. Go ahead. Can you, go to the microphone, please? Just tell us.
Hi, Hani. What's the percentage of patients with HFpEF are obese, and the percentage of those who are not obese?
You heard the question, Hani? So
no, sorry, could you repeat it?
Okay, so the question is okay, I can tell him because I don't think. You're asking about what percentage of HFpEF are obese?
Yeah, so this is a very nice question. In fact, if you look at the majority, this is what's called the obesity paradox. Actually, I didn't have time to go into this, but in fact, in HFpEF, more patients are obese and have heart failure. This is the opposite of what we see in HFrEF, because with HFrEF, you have cardiac cachexia, and they start losing weight because of the increased metabolic demand. So here, it's tied into the metabolic inflammatory phenotype, and it's noted that in the US literature, at least, the majority of patients, something like 78 to 83% of patients with HFpEF have the combination of obesity, increased BMI, weight circumference, plus all of the things that describe metabolic syndrome. So they have impaired glucose tolerance, they have insulin resistance, they have proteinuria, microalbuminuria. So if you see a pre-diabetic or diabetic patient with increased BMI and waist circumference, and they have dyspnea, don't assume it's due to the weight. Please try to evaluate for heart failure and preserved ejection fraction.
Do we monitor BNP or anti-pro-BNP to diagnose the incipient heart failure? As a clinician, should we order BNP or anti-pro-BNP?
So the question is from, again, I don't think they can hear you through the virtual. The question is, shall we use BNP or pro-BNP to assess and diagnose and prognosis of HFpEF?
Absolutely. It's a brilliant question. So the European Society of Cardiology just published a very recent guideline, 2019, in patients in the outpatient setting for internal medicine, diabetologists, and non-cardiologists. If you have a patient that presents with this syndrome, shortness of breath, lower limb edema, increased fatigue, and maybe even episodes of sleep apnea. The ECG is number one. If the ECG shows any abnormalities, and that means left ventricular hypertrophy, left atrial enlargement, or non-specific changes that are not ischemic in nature, NT-proBNP is done. Now, the NT-proBNP in the outpatient setting, the cutoff point is much lower than that in the emergency room. So for the NT-proBNP, over 125, strongly suggestive of heart failure. For the BNP, more than 30, strongly suggestive of heart failure. Here, you trigger the echo and refer to the cardiologist with a specific question. I'm thinking of heart failure with preserved ejection fraction or metabolic diabetic cardiomyopathy. This is a very legitimate way of doing the treatment. And using this approach, actually, this was studied in a nice guideline paper from 2018 by Bottle's group. This is a group that studies clinical effectiveness. They found that the patients who did not have this testing, only 24% were recognized within 5 years, but those people who had this simple testing with ECG and BNP, 78% were recognized, referred to echo, and started on guideline-directed medical therapy, which now would include RAS blockers and SGLT2 inhibitors if they're diabetic. So it will change the management, of course.
The question always been asking by the patient when we start the patient on antihypertensive and he's obese, he's asking, is there any time that I can stop my antihypertensive if I lose weight? So what would be your answer for such a patient?
So, Hani, did you hear that? So,
Sorry, I didn't hear the question again.
Okay, this is a common question people ask. One of the, you mentioned that obesity is resulting in hypertension. Patients start on medication, they lose weight, they do their best, and then they start to feel, side effects from because now become hypotensive on medication. They ask you, can they stop medication for hypertension?
I think the answer is absolutely yes. So we treat hypertension based on specific targets. And as I mentioned in the lecture, if you have a 15% weight loss, your likelihood of correcting the blood pressure is almost 15 millimeters of mercury. And the more you lose weight, the more you can do that. So we have had patients who have undergone bariatric surgery. We share many patients, myself and Dr. Abdullah. And after successful bariatric surgery, which is maintained, oftentimes these patients are no longer insulin resistant, they are no longer hypertensive, and they are no longer having even the metabolic component. So we have to reassess after bariatric surgery, not just for complications of bariatric surgery, but for the effects, the positive effects of hypertension. So really, if you have lost 50% of your body weight or 30% of your body weight, and you are no longer hypertensive, this is a success story, right? The key point is to maintain it, because some of the patients, they lose track, they lose focus, and they go back to overeating, and then they lose the benefit of the surgery. So the long-term benefit is reduction of metabolic syndrome, reduction of cardiovascular events, and ultimately non-pharmacological therapy.
So I think in the interest of time, we're going to have to, we're really running short of time. We have to move on, yeah? We can take a question later on. So I'd like to thank Dr. Hani for a very comprehensive and elegant talk as always. We really enjoyed that. For taking us through all the cardiovascular manifestations of obesity.